Welcome to the gluteal region cadaveric breakdown video, presented by Visual MD. The gluteal region is the posterior hip area essential for hip movement, stability, and posture. The boundaries include the iliac crest superiorly and the gluteal fold inferiorly. Clinically, it's a common site for safe intramuscular injections, and the Trendelenburg sign indicates weakness of the gluteus medius. Beginning with the layered anatomy, the superficial layer contains the skin and superficial fascia, dominated by the Gluteus Maximus muscle. The deep layer includes the gluteus medius and minimus, the short lateral rotators, and major nerves and vessels. This view shows the depth after reflecting the gluteus maximus. Starting with the gluteus maximus, its origin is the posterior gluteal line of the ilium, dorsal sacrum, coccyx, and sacrotuberous ligament. It inserts into the iliotibial tract and the gluteal tuberosity of the femur. Its action is powerful hip extension and lateral rotation, innervated by the inferior gluteal nerve. A spotting tip is its thick, coarse fibers. If you see nothing else, you are on it. Gluteus medius. Gluteus medius originates from the external surface of the ilium between the anterior and posterior gluteal lines, inserting on the lateral surface of the greater trochanter. Its actions are hip abduction and pelvic stabilization. It is innervated by the superior gluteal nerve. The spotting tip is its fan shape. It appears immediately after removing the gluteus maximus. Gluteus minimus. Gluteus minimus originates from the external surface of the ilium between the anterior and inferior gluteal lines. It inserts on the anterior surface of the greater trochanter. Its actions include hip abduction and medial rotation, and it is innervated by the superior gluteal nerve. It is smaller and deeper than the medius, with more horizontal fibers. A clinical correlate is the Trendelenburg sign, indicating weakness of the gluteus medius and minimus. The most common cause is injury to the superior gluteal nerve. A positive sign is when standing on the affected leg, the pelvis drops on the opposite unsupported side, signifying weak abductors on the standing side. Piriformis. Piriformis muscle originates from the anterior surface of the sacrum between the anterior sacral foramina. It inserts on the superior border of the greater trochanter. Its action is lateral rotation of the extended thigh and abduction of the flexed thigh. It is innervated by the nerve to piriformis. It is achy landmark muscle, as everything is described relative to it. Piriformis divides the greater sciatic foramen into two parts, suprapiriform and infrapiriform. Only the superior gluteal neurovascular bundle passes above piriformis. An easy way to remember the relationship is, quote, superior stays superior. Structures passing below include the sciatic nerve, inferior gluteal nerve and vessels, pudendal nerve and internal pudendal vessels, and nerves to the obturator internus and quadratus femoris. The sciatic nerve is the largest structure. This image shows the major muscles, vessels, and nerves in the gluteal region relative to the piriformis muscle, including the greater and lesser sciatic foramina. Piriformis syndrome is a clinical correlate where the piriformis muscle compresses the sciatic nerve. This can be caused by muscle spasm, inflammation, or anatomical variation. Symptoms include gluteal pain that radiates down the posterior thigh, which worsens when sitting. An exam clue is sciatic pain, despite a normal spine. Obturator internus. Obturator internus originates from the pelvic surface of the obturator membrane and the surrounding bone of the obturator foramen. It inserts on the medial surface of the greater trochanter and performs lateral rotation. It is innervated by the nerve to the obturator internus. A spotting tip is that its tendon bends sharply through the lesser sciatic foramen, and it lies between the superior and inferior gemellus. Superior gemellus. Superior gemellus originates from the ischial spine and joins the tendon of the obturator internus to insert onto the medial surface of the greater trochanter. Its action is lateral rotation, and it is innervated by the nerve to the obturator internus. As a spotting tip, remember it is small and located directly above the obturator internus. Inferior gemellus. Inferior gemellus originates from the ischiotuberosity and inserts onto the medial surface of the greater trochanter via a conjoined tendon with the obturator internus. Its action is lateral rotation, innervated by the nerve to quadratus femoris. It is small and located above the obturator internus. Quadratus femoris. Quadratus femoris muscle originates from the lateral border of the ischiotuberosity and inserts on the quadrate tubercle on the intertrochanteric crest. Its action is lateral rotation, innervated by the nerve to quadratus femoris. This is a flat rectangular muscle. This cadaveric image provides a real-world view of the deep lateral rotators, including the piriformis, superior and inferior gemellus, obturator internus, and quadratus femoris, demonstrating their relationships and the common tendon of insertion. Focusing on the neurovascular structures, the sciatic nerve originates from the sacral plexus and exits below the piriformis through the greater sciatic foramen. It runs deep to the gluteus maximus, entering the posterior thigh. A clinical correlate is injection palsy, which is acute injury from an injection given in the lower medial quadrant of the buttock rather than the safe upper lateral quadrant where the sciatic nerve is vulnerable. The gluteal arteries, originating from the internal iliac artery, include the superior gluteal artery. It exits above the piriformis, passes between the gluteus medius and minimus, and supplies these muscles and the tensor fasciae latae. It is found deep between the abductors. The inferior gluteal artery exits below the piriformis and runs with the sciatic nerve. It supplies the gluteus maximus and deep lateral rotators. When spotting, remember its close proximity to the sciatic nerve. The two main ligaments in the region convert the sciatic notches into foramina. The Sacrotuberous ligament runs from the sacrum to the ischial tuberosity, forming the boundary of the greater and lesser sciatic foramen. It is a thick ligament going to the ischial tuberosity. The Sacrospinous ligament runs from the sacrum to the ischial spine. It divides the space into the greater sciatic foramen above and the lesser sciatic foramen below. It is a smaller, sharper ligament that goes to the ischial spine.
That's Visual MD. If it helped, subscribe, and I'll see you in the next one.